reke ndimite conference twinayo muthi nĩ kũgeria kũ address ũhoro wa atumia breast reconstruction arĩa mathiĩte through surgery makarutwo nyondo ũrĩa tũngĩcokia nyondo ĩyo na surgery nĩgetha mũndũ akoneka arĩ o mũgima, na atumia aingĩ nĩ makoragwo magĩcaba nĩ tondũ mathĩnjwo na marutwo nyondo matirĩ na njĩra ya gũcokia nyondo ĩyo through surgery. Nĩkĩo twĩna conference ĩno na twĩna mandagĩtarĩ experts kuma mabũrũri maigana ũna, kuma US na kuma Canada, kuma Italy, kuma Argentina, kuma Ghana, othe me gũkũ nĩgetha tũgerie ku-address ũhoro ũyũ wa breast reconstruction. Na kiumia gĩkĩ nĩtũgũthĩnja atumia 10 arĩa ma-identify mena problem ĩyo, mathĩnjwo macokio akorwo marutĩtwo nyondo macokio nyondo ĩyo na njĩra ya kĩrĩu, na ndĩrakema nĩ ũhoro ũcio tondũ aingĩ na makirĩte mĩciĩ nĩ mathĩnjirwo makĩrutwo nyondo na matirĩ na njĩra ya kuoneka gũcoka ũrĩa mahanaga nĩgetha mariganĩrwo nĩ ũhoro wa cancer. Nĩ mahonire na nĩ wega, no matiriganagĩrwo nĩ ũhoro ũcio tondũ nĩ marakĩona kĩrema kĩu. Koguo nĩkĩo twĩna symposium ĩno na macanjoni maitũ gũkũ Kenya, na rĩu tũkarehe aya kuma na nja nĩgetha tugerie kwaria ũhoro ũcio, tuone atĩa thibitarĩ ĩno ĩngĩtuĩka nĩyo Center of Excellence for Breast Reconstruction nĩgetha ĩteithie Kenyan women arĩa mena problem ĩno. Thĩinĩ wa thogora nĩ tũrageria mũno kwaria na thirikari nĩgetha NHIF kana now the new authority, social authority ĩgerie rĩu gũ-support atumia aya nĩ ũndũ rĩu mathĩnjwo nĩgetha tũmenye ti ũhoro wa kuoneka wĩ mwega, nĩ ũhoro wa mental health, nĩ ũhoro wa self worth, kwĩenda na kuona nĩ ũikarĩte wega. Koguo nĩ tũkwaria na thirikari na njũĩ thirikari nĩ gwĩtĩkĩra nĩgetha NHIF kana the new social health insurance fund ĩgerie rĩu support atumia aya. No na ithuĩ thibitarĩ nĩ tũreciria ũhoro wa foundation, the Kenyatta University Hospital Foundation, tondũ tũkĩgĩa na foundation ĩyo na tũcarie mbeca, rĩu atumia mangĩũka ona matarĩ na mbeca nĩ tũkũmateithia nĩgetha rĩu tũmateithie just to improve the quality of life of these women. Namba ya cancer patients nĩ ĩrongerereka mũno. Ngwĩciria rĩu tuonete arwaru ta 80,000. Nacio ĩyo nĩ namba nene mũno, kwĩ ĩrathiĩ ĩkĩongerereka o ũrĩa andũ maramenya, na ithuĩ nĩ tũramatua aware na tũramera mũno onakorwo ndwaigua wĩna ruo ũthiĩ thibitarĩ ũrorwo. Na nĩtũrona arĩa maroka na matarĩ na ruo, nĩtũrona amwe ao no arwaru, no ruo rũtirĩ rũroka. Na nĩguo tũrera Kenyans mathiĩ screening, mathiĩ marorwo, onakorwo ndwaigua ruo ũrorwo nĩgetha akorwo nĩ ũkuoneka wĩna problem ĩtreatwo tene, tondũ mũrimũ ũyũ woneka tene chances cia gũ-survive nĩ nene. No woneka rĩu stage 4 na igũrũ andũ aingĩ maroka me stage 4 na stage 3, rĩu na gũ-treat amwe nĩ makĩhona tondũ ndagĩtarĩ mehona nĩ ogĩ, no chances cia gũ-survive wĩna stage 1 nĩ higher gũkĩra wĩ stage 4. Koguo mũrimũ nĩ ũrongerereka, no nĩ ũrĩa ngiuga nĩ andũ marorwo, onakorwo ndũraturwo ũthiĩ ũrorwo nĩgetha wonekane tene nĩgetha ũhote gũ-treatwo tene. Kũrĩ andũ aingĩ maroka marwarire mĩaka 2 mĩaka 3 mĩthiru, maiguaga ruo makanyua panadol, magathi makaheo tũtawa ũguo na matirarorwo. Koguo no nyende kwĩra Kenyans makarorwo, ũgatuĩka very keen, nĩkĩ kĩratũma ũturwo mwaka ũmwe mĩaka 2 ũgathiĩ ũkarorwo. Na ndagĩtarĩ aitũ nao ingĩenda kũmera nao arwaru moka matiga kũmaiga mũno mataroretwo, kũmahe ndawa thiĩ ũcoke makamarora tene nĩgetha mũrimũ ũyũ tũhũrane naguo o tene wa present.
And I'm just delighted to be here, and so it is inspiring to see the work that is being done here, focusing on women with breast cancer and really fulfilling their needs. For a woman who's had a mastectomy for breast cancer, who has survived her breast cancer, breast reconstruction is critically important for her to be able to put her life back on track and put the breast cancer behind her. And these efforts to increase plastic surgery capacity, the knowledge, this is such a skilled team already, but to be able to bring together as a community of breast reconstruction surgeons to share knowledge and expertise so that women of Kenya will be able to have access to breast reconstruction, I think is so important. I would also say that the issue around women presenting quite late with breast cancer, I think one factor is that when they know that there is no access to breast reconstruction, a woman may stay at home knowing that she has a breast cancer because she fears mastectomy. So I think there's also potential to make it that women might present, young women may present earlier with their breast cancers, knowing that mastectomy is not the end. So congratulations on the efforts of this amazing team. I think Kenya is at the beginning of its journey. I think that the needs of women, the fact that we're highlighting that, they're at the beginning of that road. There is definitely the technical knowledge. There are incredibly skilled surgeons here, but I think the combination of bringing together the multidisciplinary teams, the resources, the leadership support, the government support to be able to provide access. All the pieces are here. Everything is here, but to your point, I think they are not. I think this is just the beginning of a journey to be able to provide the best care to breast cancer patients.
I think that the most important is the power of the government to still pushing, investing in education. But with education is the best way to change the life of patients. So thank you for the invitation, and from this moment we are friends from Nairobi, Kenya, and we'll still coming. Thank you.
The symposium that we are holding this week is on breast reconstruction. As you know, we have a big problem with breast cancer, and once the surgery is done, then a lot of patients are left with scars, with a flat chest, having lost their breast because of cancer. So we are focusing on breast reconstruction, and the reason why we are doing that is that we can give these women a new lease of life. A lot of them don't know what to do after the surgery, they don't have the knowledge, they don't have the resources, and therefore as a hospital, as one of the best cancer centers in the country, we are now thinking of how can we also help these women get their life back by doing breast reconstruction, where the doctors are able to reconstruct their breasts so that now they can live as normal. And honestly, after the breast cancer and surgery, you don't have to go showing everybody that you had an issue when actually you have healed. So that was our reasoning. The symposium is very well attended. As you can see here, we have breast surgeons, experts from different countries. We have experts from Argentina, from Canada, from Italy, from Ghana, and from US. Yes, so we have from these countries very, very experienced breast surgeons to come and work with our own breast surgeons. From this hospital we have Dr. Moki and other doctors. So they will be working together, and the rest of the week we will be actually operating on, I think, 10 women doing the breast reconstruction, and the doctors will be sharing their experiences. We have some doctors who have more experience than the others from other regions, and they'll be working with our doctors so that we can begin to build capacity. They share knowledge, they share experiences, how to get the best outcomes. So that is really the essence of the symposium. You can imagine we have seen that 3,000 women in the small breast care center that we started with Dr. Moki and colleagues. So if we make it a bigger center, a regional center, probably to even be 10 times more. Because if you look at PET scan, patients are coming from the region, from Rwanda, from Ethiopia, from Tanzania, everywhere. So if you make it regional, I am not surprised if that number even becomes 10 times. Because as you saw the statistics, 20% of our cancer cases today diagnosed here are breast cancer. So these are, and I'm sure this is the same in other countries. So we hope to reach more people in an effort to save more women.
I think probably in terms of the diagnosis of breast cancer, I think we are okay. The treatment options are available, but like you have heard that we have concerns regarding the untimely presentation of patients, that most of our patients present in the later stages. So that's obviously a challenge. Then another difference that we have to probably from patterns of breast cancer presentation in the West is that we also have younger patients who present with breast cancer. So that's also a challenge. Then if the only option that we can offer these young patients who present late with breast cancer is a mastectomy, then of course we can see one of the challenges that we'll get is that they will not present, or we make the diagnosis and then they disappear. So some of these collaborations that we are doing and some of these symposiums that we are doing to show that there are options of treatment, they will probably improve in terms of our outcome and how patients present.
Are absolutely key to this. So specifically in terms of what's available here, that I can't speak.
Person has come 2 years later, then straight away continue, or the window has already been missed. We can't tell. So
sophisticated our reconstruction. About the skin panel design, you use a small panel of skin, and horizontal is very good for you can put the scar inside of the ground, and we use this and this one. There is no morbidity movement. Or CTA with the perforator is very important because a lot of patients. Hello, and big axillary push, you can see the border of the muscle. If you have you can use it with tissue expander as a matrix, and then you can change the expander for a
$500, then that means it's probably more than 2,000 who require.
Okay.
On some other people here, the symposium, and who are participating.
Okay.
Procedure, and also that most of the insurers breast reconstruction. What are your thoughts? Become at stage 3 or stage 4.
Yeah.
Can you expound?
Mubango wa Cancer Center ya ciana wiho na
to restore the function, especially the upper limbs and the general activity of the patient. So, do you have timeline like when you expect?
there is no restriction. They start quickly and fast. And in fact, it's always important for them to start early, just to.
I apologize to bring you back to the radiotherapy question, but when you mentioned when to start your timing post radiotherapy to touch the patient, you said 1 year minimum.
It is timing from when we put in a tissue to when we do the implant exchange from the tissue expander to the permanent implant is what I'm describing as the 1 year.
What about a
Timing from radiotherapy to resident tissues to stretch or to do anything significant. You're bringing in fresh tissue, fresh blood supply.
I have a question for Dr. Muki. What's your experience with the situation is here? Do you often have to do symmetrizing reductions, or you?
So most of the time, in terms of volume, for the patients that we will choose small cut size, or not full mastectomy. So you bring for those who are a bit larger, then you will.
I wanted to find out if there are any leadership going to grow in numbers, so I would like to know how it was beneficial. Thank you.
The BMI was low, so we did not have the option of using an autologous reconstruction. So we decided to go for a question to all the faculty, visiting faculty. What do you do? Because it's one of the cases that I think we'll see.
I'll just make a quick comment about the question about nursing leadership. Thank you for that, because I think